Hi, I am Dr. Senthil Nathan, Professor, Department of Oral and Maxillofacial Surgery. I have 16 years and 6 months of experience in maxillofacial surgery. Okay, today I am going to talk about orbit. In the orbit, surgical anatomy of the orbit. Orbit is a quadrangle pyramidal in shape. Orbit floor has thin volume of 0.5 mm and A-shaped concave anteriorly and convex posteriorly. Bones placed in the orbit. Orbital plate of maxilla, zygomatic perpendicular plate of palatine. And the foramens and fissures in the orbit present. Lesser wing of sphenoid, greater wing of sphenoid, infraorbital foramen, that infraorbital nerve will emerges out of the orbit. There are various dissection techniques in orbit. Subperiosteal dissection technique. The inferior orbital rim close to the infraorbital foramen is 20 mm. Frontozygomatic suture to the supraorbital fissure is 35 mm. Infraorbital rim to optic foramen is 45 mm. The safe distance is 30 to 33 mm for the dissection techniques. Then comes classification. Classification of the isolated fracture of the orbital rim, superiorly, inferiorly, medially, laterally. Isolated fracture of the orbital wall, roof, floor, medial and lateral. Internal orbital fractures. They are classified into linear blow-in and blow-out fracture, that is otherwise called as pure and impure fractures, and complex fractures. Complex wall of the fracture. Orbital floor fracture is treated by trapdoor effect, severely disrupted floor, completely disrupted floor. Fractures of the orbital rim and associated wall. Superior orbital rim, highest resistance to impact. Frontal sinus, lacrimal gland, subconjunctival hemorrhage may involve the cranium. Orbital floor fractures, isolated cranial orbital fractures and orbital facial fractures. Zygomatic fractures and naso-orbitoethmoid fracture. LIFO 2 and or LIFO 3 fractures. Panfacial fractures. They come under orbital floor fractures. Blow-in and blow-out fractures. Pure and impure fractures. Buckling theory is merged inside the blow-out fractures. Retropulsion theory is the retrieve the position of the eyeball. Clinical feature of orbital fractures. Periorbital tissues, periorbital edema, circumorbital ecchymosis, subconjunctival hemorrhage, and the other clinical features in eye or diplopia, anophthalmos, pupillary reflexes, and limitation of ocular movement. Ligaments tear in the alteration in canthal level, alteration in ocular level, telecanthus, eyelids, abnormalities of palpable pressure and ptosis. Lacrimal apparatus involved epiphoria, wounds involving the punctum. Neurological deficits or paresthesia, paresthesia of extraocular muscles, paresthesia of facial nerve. Force reduction test is done to the lower eyelid is being force reduction test is being done to check the ptosis, epiphoria and other ligament tear in the complications of orbital fractures. Radiographic evaluation, high resolution CT, coronal, sagittal, XL, 3D reconstruction, volumetric assessment. Treatment options. Patient with orbital fracture, visual function is decreased and CT scan. Steroids 30 mg per kg methylprednisolone. Retrobulbar hematoma, blow-in fractures, decompressive surgery, orbital decompression, optic canal decompression, nerve sheath. Visual functions normally decreased vision, immediate fracture repair, steroids for severe fractures. Immediate fracture repair, steroids for severe fractures. Patient with orbital fracture will cause visual function and normal immediate fracture repair, steroids for severe fracture is given. where decreased CT scan and steroids 30 mg per kg prednisone. In CT, retrobulbar hematoma, blow-in fracture, decompressive surgery, orbital decompression, optic canal decompression, nerve sheath. Decreased vision, immediate fracture repair, steroids for severe fractures. No vision improved, yes, immediate fracture repair, steroids with severe fracture. Orbital floor fracture. Indication for orbital floor fracture. Persistent diplopia with positive force reduction. Obvious ophthalmos. Comminuted orbital rim by CT scan. 50% of the floor disruption by CT. Combined floor or medial wall defect by CT. Fracture of zygoma body by CT. Orbital floor best done in 7 to 10 days after the fracture. Other indications is 1 to 2 square centimeter of the floor is disrupted. Contraindications appeal in the orbital floor fracture is hyphemia, retinal tear, globe perforation, only seeing eye, medically unstable. Objective of orbital floor reconstruction: restore structure and function of reconstructing large defects, prevent long-term complications and sequelae. Prevention herniation of orbital contents into maxillary sinus. Prevent herniation of orbital contents into maxillary sinus. Factors influencing choice of material for use in orbit. Size of the defect, number of walls involved, adaptation to internal contours, reception of proper volume, presence of adjacent sinus cavity, prevention of displacement, adhesion and restriction of ocular mobility. Material used in orbital reconstruction. Autogenous and autologous materials. Graft transferred from one part of the patient body to another is autogenous. Septal cartilage, ear cartilage taken from septal cartilage, ear cartilage, maxillary bone, iliac crest bone, rib cartilage and split calvaria. Allogenic or xenographic materials. Graft transferred from another person, homogenic or allogenic or from any animal or different species is xenographic materials. Example: lyophilized dura, lyophilized cartilage, banked bone. Alloplastic materials. Graft derived from non-living source, synthetic. Medpore, polytetrafluoroethylene, methyl methacrylate, polyimide mesh, titanium, vitalium and other metallic mesh. PGA or copolymer implants. Orbital titanium mesh are being used. These are advantages in using an orbital titanium mesh. Easy to use, eliminate donor site morbidity, decrease operative time, numerous shapes and size available, abundant supply. Disadvantages: foreign body reaction and rejection, extrusion, infection, unpredictable long-term efficacy or safety. Orbital floor reconstruction. Key area is the shape of orbital floor is posterior third. Transition zone between orbital floor and medial wall. Orbital floor reconstruction using navigation. 3D dimensional repair of orbital floor. Provide accuracy of bone reduction. CT base and virtual reconstruction were transferred to intraoperative navigation system. Surgical probe placed on the operating site will be viewed in the monitor. This will project the exact location of the probe in the axial, coronal, sagittal and three-dimensional views. Conclusion. Goal is a functional and cosmetic rehabilitation. Precise anatomic restoration is the key. Knowledge of anatomy and techniques leads to superior results. This is the brief introduction of orbit, and today I have spoken well about orbit so that you may understand about the orbit and you can read about it in a leisure time and make use of this orbital discussion in a good way, and so that it may be useful to you. I will meet you after another interesting topic. Thank you.